La. All right, we make it here again. Hey, good job on that last test, people. We survived. So now, really, we just have to continue doing well, continue surviving. Well, and that next aspect of surviving, that includes learning about renal failure. Yay! Oh my goodness, that is so fun and exciting. Still waiting for my coffee to kick in, I think. So, don't worry about that. That's a fun surprise we're saving for later. Okay, renal failure. They have here a question of what did the kidneys do for us? Well, the kidneys do a lot of freaking things. Mainly, they have a part to play in electrolyte balance, specifically with sodium and potassium via the RAAS syndrome, renin-angiotensin-aldosterone. Yeah. Which also helps to deal with like vasodilation and everything. So, huge part to play in fluid balance, as well as the regulation of our blood pressure via our fluid volume. And they have here fluid balance, which is also, they also have a part to play in the ADH hormone, which, let me see, how does the kidneys affect ADH? Antidiuretic hormone. So kidneys respond to antidiuretic hormone, adjusting the amount of water that they reabsorb, essentially conserving water in the body when ADH levels are high and releasing more when it's low. Okay. So ADH, like kidneys don't actually affect ADH. ADH affects them, which I believe antidiuretic hormone is produced by, let's say, okay, we'll put a bet, okay? It's going to either be the, goodness, the, what is that thing in the head? The, oh my goodness, hypothalamus or the adrenal cortex? Hypothalamus, we're freaking in, people. Hypothalamus. Which one is the adrenal cortex? Which P hormone does the adrenal cortex produce? Aldosterone. Ah, yes, adrenal aldosterone. Okay. Antidiuretic hormone is produced from the hypothalamus. Okay. Anyway, that's not important. But they both just, their target, like, organ is the kidneys. Because the kidneys are the ones that ultimately do all the water filtering and pee stuff. All right. The kidneys also stimulate red blood cell production via erythropoietin. This is kind of a cool little hormone. Like, essentially, the kidneys are always seeing how much oxygen is in the blood. And if the kidneys ever sense that there's not enough oxygen in the blood, they'll just be like, hey guys, I think we need to make more red blood cells. And so then they do. They create this erythropoietin that causes the body to make more red blood cells, which at the end of the day will be able to carry more oxygen. That's the whole deal with red blood cells, is that we make them so that we can have more red blood cells, which have hemes that can carry oxygen to the tissues, blah, blah, blah. They also deal with acid-base balance because their part to play is reabsorbing or like getting rid of. Those aren't mutually exclusive. It's actually getting rid of or reabsorbing bicarbonate. That's why in like respiratory acidosis or respiratory alkalosis, one of the ways that the kidneys can compensate in a day or 2 or 3 is that they can create urine, which is trying to get rid of that excess acidic thing. So if we're in a respiratory like acidosis, okay, we're not getting out our carbon dioxide, then the kidneys may produce more acidic urine because they're like, well, we need to pee out the acid. We've already got plenty of acid in here, and vice versa. or I guess the question is, the kidneys are going to hold on to bicarbonate and pee out acids, and then vice versa. If we're in some sort of state of alkalosis, the kidneys will be like, if the kidneys are working, they'll say, let's pee out some bicarbonate and hold on to that extra acid, because we're going to need that. Okay. The kidneys also produce calcitrol, which helps to absorb vitamin D. D is not there. But, yeah. So, calcium. Calcium is a really important hormone for both our bones. Yeah. Our bones and our muscles. Let's see. What? Okay, builds strong bones and teeth and supports muscle contractions, nerve function, and blood clotting. Blood clotting. Interesting. Well. So, but here's the thing, right? Your body needs vitamin D to absorb calcium. Need vitamin D to absorb calcium. Okay, it is okay, well, what the frick? It helps your body to absorb calcium. I want to know why and how. Helps your intestines absorb calcium. Okay. I want to know how. How does your body use vitamin D3 to absorb calcium? Increases the activity of calcium transporters in your intestines. So it really just happens at the GI level. That's interesting. Oh, that is very interesting. So yeah, we need vitamin D in order to really hold on into and grab that calcium, and that calcium is important for bone health, to help our muscle contractions, to help our neurons fire properly. And unfortunately, without calcitrol, we can't really absorb. I want to check that, but it's like, what does calcitrol do? Treats low calcium levels. Increases the amount of calcium in your body. Why does it say calcium in parentheses vitamin D? So it increases the vitamin D in your body. Plays a calcium regulation, the parathyroid hormone, enhancing absorption from the gastrointestinal tract, promoting renal tubular reabsorption of calcium. Okay. Calcitrol is actually the most active form of vitamin D. Okay, so wait. Do the kidneys produce calcitrol? Yes, they do, which is the active form of vitamin D. How it's produced. They produce cholecalciferol when exposed to sunlight. The liver converts calciferol to calcidyl. Oh my freaking goodness. That's just too many letters for me. Guys, I don't think my brain is big enough for these letters. Oh my goodness. Vitamin D is fat soluble. So, yeah. So the liver, it has to go through the liver first. But after your liver converts the vitamin D, which is the cholecalciferol, to calcidiol. Calcidiol. Okay, oh my goodness. And then the kidneys convert that calcidiol to calcitrol. Oh my. That is so stupid. Calcitriol? What the frick? And then this calcitriol is the actual way that we use vitamin D to help our calcium. Oh my goodness. So basically, if you take vitamin D and your kidneys aren't working or your liver isn't working, it doesn't really do much to help you absorb calcium. That's what I'm getting from this. Because there's this whole process of our body getting vitamin D, and then that vitamin D going to the liver because it's a fat-soluble vitamin and getting fixed in whatever from cholecalciferol to calcidiol, and then it traveling down to the kidneys and converting that not quite active form of calcitriol to the active form that allows our GI system to, in turn, get more calcium from the food that we eat. Okay. We're on the first slide. We are on the first slide. Okay. Cool. And of course, this is a long-term thing. Like, you don't just, well, unfortunately, we didn't meet our calcium quota today, so you have osteoporosis. No, that doesn't happen. But long-term, in the chronic state of having bad kidneys, because the kidneys are the actual thing that creates the calcitriol, okay? Calcitriol? Whatever, okay? Whatever. If your liver's not working, it stops there. And it's like, womp womp, you never had the chance. Or not much of a chance. If the kidneys stop working, you're still not going to get it, right? You're still not going to get the calcitriol. So, you're long-term not going to be able to get enough calcium to support good bone health, proper muscle contractions. Because calcium is like, as far as I can remember, calcium is like, I want to check, but I think calcium is like, yes, let's go. Let's continue muscle contracting. So if you have like too much calcium, let's look at hypercalcemia. Oh, that's not exactly what I was looking for. Abnormally, blah, 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 blah. La, la, la. So, yeah. Many people have no symptoms: fatigue, confusion, nausea, vomiting, constipation, kidney stones, bone pain. Cool. What about hypocalcemia? Okay, muscle cramps and spasms, tingling or numbness in the fingers, toes, and around the mouth, seizures, confusion, brittle nails, dry skin. Okay, let's what does calcium do in the muscles? Helps the muscles contract, repair damage, and excess energy stores. Okay, allows actin and myosin to interact and cause contraction. So that's interesting that in hypocalcemia, which is not having enough calcium, you get these cramps where the muscles almost contract weird. Hold on. Why do you get weird muscle cramps with hypocalcemia? I don't want to go to Reddit. Can't I just get my AI overview? Thank you. Stabilizing nerve cell membranes. And when calcium levels are low, nerves become overly excitable, causing tetany. Okay, so now it's all coming back. Calcium is like a bit of a gatekeeper. He allows some things to go through and some things to not go through. If there's not enough calcium, then everything wants to go through. The nerves are like, okay, yeah, you want to do? Yes, let's try this. And so now we have too many things telling the muscles to go, essentially, which can cause tetany, which is obvious, right, through our Trousseau's and Chvostek's sign, hyperexcitability. Trousseau's sign, of course, is if you put that blood pressure cuff on that person, blow it right up, their hand is going to, like, you're going to have, like, extreme, like, supination. Kind of, not really. I'm trying to think of the right word to say. You're going to have, like, extreme flexion at the wrists, drawing towards your body. Your hands are going to all kind of get, like, pulled in as well. That's Trousseau's sign. And Chvostek's sign, if you tap that person's cheek, they're going to kind of twitch. They're kind of twitch with it. So calcium helps to maintain the resting potential of nerve cells. And of course, if there's not enough calcium, then the resting potential is a time where it's where the cell is resting, where the nerve membranes are not like too excitable. The resting potential then being how much of a nerve impulse is this cell going to need to actually do what it needs, right? And that impulse can be a bunch of different things. That could be a reflex, or it could be, especially in skeletal muscle, a voluntary nerve impulse, right? But in the if there happens to be a little bit of a nerve flick at it, a little tiny little shock of electricity coming down from the big head, but it's not anything big, it won't essentially reach the resting potential. The resting potential is this hill that any sort of nerve impulse needs to get over in order for the muscles to do its thing, to actually get that nerve impulse, to get to the muscles and say, we're doing this, right? Because you don't want your muscles to be acting at every time there's any sort of impulse. So it's kind of like this, you gotta be important to get into this club, kind of thing, right? Now, that calcium, since that is maintaining that resting potential, the less calcium there is, the less of a climb that hill is for any sort of nerve impulse to get through it, which is why you can have tetany and nerve cramp, and muscle cramps, because there might be, tetany, by the way, is when there's just this constant shock of impulse to keep that muscle flexed, right? Or extended, whatever sort of like constant muscle action, right? And so in the case where you don't have enough like calcium to sort of be like, hey, no, you don't reach resting potential, our resting potential guideline, you don't meet our recommendations for for our resting potential, you don't measure up, you don't have enough importance to make it here. When that's low, when there's no standards for what can go in and what can't go in, everything can kind of go. So you can have twitching and muscle cramps and whatever. All of that to say that not having calcium is a bad thing. We want to have calcium, okay? And if our kidneys are having problems, we're going to be seeing issues with sodium, potassium, calcium, and where calcium goes, okay, phosphorus goes in the opposite direction. Calcium and phosphorus are like arch enemies, so that's how I've had it heard. So if calcium is down, phosphorus will be increased. And yeah, magnesium's there too, but we'll talk about him like in a second. Anyways, some kidney terms. I think that's it. Yeah. Oh yeah. One last thing. The term for a renally induced hypocalcemia is a renal osteodystrophy, because long term it causes the bones to be not strong. Okay. Kidney terminology. Azotemia. Okay. Nitrogenous waste buildup in the bloodstream. Wow. Nitrogenous waste. What is nitrogenous waste? Sorry, I gotta text people back. You know how it is, being so popular. I'm just kidding. I have one friend. Guys, I've got one friend. Alrighty. So, nitrogenous waste, now this is gonna blow your freaking mind, is any waste product that contains nitrogen. What? Are you kidding me? This changes my whole... Whatever. It's created when proteins and nucleic acids are broken down for energy. Of course, via what's it called? The uric cycle? Hold on. Cycle. Uric acid cycle, whatever. That's too small. That's too small. Okay. Food intake, proteins, that's not useful. ribose, uric acid, blah, 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 blah. Purines. There we go. Purines. I'm trying to find exactly the right picture. Okay? That's not it. Open image in a new tab. Well, that's so freaking small. I can't read that. I can't read! Hey guys, I can't read. La la la. La la la. La la la. Well, well, well. Finally, ammonia. Ammonia! Okay, and of course ammonia is NH3. Yeah, I knew that. So, in the uric acid cycle, okay, yeah, anyway, ammonia. And that's part of the waste products here. 'Cause, what is urea made from? Ammonia and carbon dioxide. Of course, and ammonia is nitrogenous waste because it's got a nitrogen in it. What are some examples of nitrogenous waste in body? Boyd? Alright. Uric acid and ammonia. Buddy, I guess that's it. Huh? I guess that's it, baby. What the frick? Well, guys, what I've learned here is that when proteins are being touched, when proteins are being touched in the body, then we get nitrogenous wastes. Now, why is this important? Well, nitrogenous wastes, like uric acid and ammonia, are excreted through urine. Now, this whole thing that we're talking about here is kidney disease, where our kidneys, which, by the way, is like the central component of our urinary system, decide, hey, you know what? I can't do this anymore. I quit. Forever. So now your kidneys aren't able to do what they need to do, okay? So in the event that your kidneys suck, okay, they're not good, then you get this nitrogenous waste buildup in the bloodstream. Cause now you can get that same kind of weird nitrogenous problem if you've got liver disease, but remember, you're still able to get rid of your ammonia. Okay, it's just not as well, made, even. You're not even, yeah. It can still get to the kidneys and be excreted. In this case, let's say the liver is working super duper well, and the liver goes, hey man, here's some ammonia, we've been making some proteins lately, or we've been absorbing some proteins lately, we need to get rid of this stuff. And the kidneys are dying. They're literally on hospice. They're like, I don't think I can do that for you. So, we have this nitrogenous waste buildup because our kidneys aren't connected to the GI system. What? Yes, they're not. But they are connected to the blood system. So if your liver wants to get rid of its ammonia that it makes from building up your proteins or whatever, or breaking down proteins in your food, yeah, so you can use it as ATP. So, then, sorry, I'm getting all these texts and I'm trying to focus. So, in the liver's highly vascular, so it say, hey, bloodstream, can you carry this to the kidneys? And the bloodstream goes, okay. So it carries it to the kidneys, and it gets to the glomerulus stopping point, and it goes, hey, we've got this crap for you. And the kidneys are like, I can't, I'm dying. We're about to retire, dude. Can you take that anywhere else? And the blood is like, not really. Well, and then and the kidneys are like, you know what? I don't even care. I'm sure you can dump it into the poop tract like you do with everything else, huh? And the blood is like, well, okay. So it travels back to the liver, and the liver's like, this is nasty. Why did you hold this the whole time? It's not doing anything good for you. And the red blood cells are like, we can't get rid of it. So the liver's like, well, whatever. I guess we'll just dump it with the bilirubin into the freaking GI tract. But long term, that's not good, and there's too much of a waste buildup for that ammonia to be effectively gotten rid of. So you have azotemia. Let me make sure that like everything I just yapped about for 5 minutes is correct. In kidney disease, will the liver send the ammonia out through the GI tract? Carried to your kidneys, okay. That's so dumb. La 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 la. La 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 la. La la la. Let me look this up. Can your GI system get rid of ammonia? Yes, it can. Detoxified, when the ammonia levels in the blood get too high, can cause blah blah blah. Okay. What the frick plays the main role? Released in the bloodstream, transported to blah blah blah, converted to the kidneys, blah, where it's eliminated in the urine. Okay. How about this? Can you poop out ammonia? Pooping can help get rid of some ammonia. This is okay. Liver neutralizes and helps your body get rid of it. Some ammonia is excreted, but it's small. Laxatives can help decrease. Yeah, because I was sitting here and I was like, well, you can give laxatives to help decrease ammonia. But I was like, that's only if... Okay, so I was right. At the end of the day, I was right. I wasn't just yapping. But your body would rather get rid of ammonia through the kidneys. That's kind of one of their main roles. When the kidneys say, no, I'm about to retire forever, how about you just take that right on back? The liver goes, well, what the heck, dude? We can't get rid of all of this in the GI tract. Anyway. La, 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 la. Stool that smells like ammonia may indicate a problem with the liver or digestive system. Awkward. Can you poop out ammonia? Kidney disease. While you can't directly, some ammonia can be eliminated due to bacteria in your intestines. It's not the primary way that it produces ammonia, and a significant buildup can still occur in the blah blah blah. Gotcha. So basically, womp womp. If your kidneys aren't working, your liver goes, well, that's just too bad. We're going to have to deal with this ammonia now until the kidneys can get their crap together, right? Meanwhile, one of the things, if you have got like crazy high ammonia, which can cause that astrixis. Yeah, we remember that. Do we all remember that? Yeah. Anyways, long story short, to make a long story short, I put a whole pack of jelly beans. Alright, anyway, oliguria. This is the least complicated thing that azotemia was so complicated. Now we're going to move on to, well, in oliguria, you don't have as much pee as you should. So, okay, how much pee are you supposed to have per hour? 30 milliliters per hour. I'm so glad we got that correct. Now, in oliguria, in a day, which is 24 hours, to anyone who didn't know, you have 400 milliliters, at least, give or take. Now, let's do some quick math. If I'm doing 30, okay, 30 times 24, that's like, what? 30 times 24... 420? Hold on. 720. Hey guys, I don't know how to do math. I multiplied 2 times 3, and I said, yeah, that sounds like 3. But oliguria is basically a little bit less than, or a little bit more than half of what we should be having every day. A little bit more than half. So that kind of sucks. But hey, what do? So if you've only got 400 milliliters total output in a day, that's what they'll call oliguria. Oligo, you meaning like difficulty-ish kind of, and then urea, so you're having decreased urine output, difficulty peeing. But you're still peeing though. You're still peeing. Of course, anuria is no or very little urine output. That's less than 100 milliliters in 24 hours. That's so ridiculous. That's so little. That's not much at all. Holy crap. That's terrible. Oh my. Oh, that's not good. That is not good at all. That's like 14% of your total daily. Cool. Yeah. Not a fan of that one. Sorry, I'm reading texts again. Right now, when I'm deciding to study is apparently when everyone wants to be texting. Guys, I'm busy! I'm busy right now! Renal failure. Yay. Renal failure. So we talked about what the kidneys do, or what they're supposed to do, and some things that happen when the kidneys don't do what they're supposed to do. But let's talk about when things go terribly, terribly wrong. Yeehaw. Now, when things go terribly, terribly wrong, there's 2 ways that they can go wrong quickly. Okay, nobody could have expected you were going to have kidney problems today. That is an acute kidney injury. Okay, or an AKI. Or an AKD, acute kidney disease, okay? Yesterday, everything was rocking and rolling, and then, maybe today, were in a car accident, you were bleeding out, now you're in a hypovolemic shock, and now your kidneys aren't getting perfused. That's an acute kidney injury. Yesterday, things were rocking and rolling. Today, your kidneys are dying. Hey, it happens, bro. It happens. It does. It's not good, but it does happen, okay? That's an acute kidney injury, all right? They said sudden onset, hours to days. That is, those days kind of a thing is if you are not getting enough fluid for like 3 days, okay? My professor has a really fun way of describing it. It's like, imagine you're like a little old lady, you fall, you can't get up, now you sit on the floor of your house for like 2.5 days, not eating, not drinking, you're stuck there, perhaps in pain, maybe you're bleeding, and if you had, had Life Alert or something, or some sort of, maybe you fell with your phone or something like that, maybe you wouldn't be in a hypovolemic state, but here you are, okay? So hours to days, and in that time, your kidneys can be seriously injured, right? Because your kidneys, blood flows to them, around them, through them, and if there's not a whole lot of blood going through them, right, they're not going to be able to breathe. They need oxygen too, just like everything else. They're kind of a vital organ, and so they're going to be less able and less effective in doing their job. Now, here's the deal, right? Here's the deal. Kidneys are really resilient. Your kidneys and your liver, they deal with stuff all the freaking time. They are like the waste processors in your body. Your liver more so, but your kidneys aren't slackers either. Now, where the liver has been known to regenerate itself, its kidneys don't. Kidneys work hard until they literally can't work hard no more, and then they die, okay? Now, when we're talking about kidneys being able to do their job, that comes down to the nephrons, okay? Nephrons. I freaking remember those stupid nephrons. Nephron. La la la. Look at these goobers. Pow. So your nephron, and you've got like a ton of these. A ton of them. All in there, okay? All up in that cortex. I think that's what it's called. Hold on. Kidney anatomy. Renal cortex. Renal cortex, renal medulla. So you've got a ton of nephrons, right? Because you've got the I want to check. I've got my stuff right here. You've got unfiltered blood that pops in through, and it looks like it's arterial blood here. Arterial blood is popping out through here. It goes to the glomerulus, which is kind of like our filter. Okay, goes into the glomerulus. The glomerulus essentially picks out things that they don't like. They pick out the things based on a bunch of hormones that have been released in your body. They'll say, well, we need to take this, we need to take this, we need to take this, you can keep this. And then the filtered blood then goes back in. They have this here, kind of, it looks like it goes down into the loop of Henle. That's what that's called. Where it gets more filtered. Oh, this is so complicated. Loop of the nephron. That's the loop of Henle. La la la. Look at this total disaster, bro. Look at this total disaster. So it goes all up in here. It looks like it's a capillary thing, so maybe this is where it gives some of that extra beautiful oxygen. Some of that beautiful oxygen to this whole process here. All those convoluted tubules. Yeah, because look, that does look convoluted. That's like the definition of convoluted. Then after it's oxygenated, it pops back into the vein, and then it goes into circulation again. Okay, that's a good enough distinction. So during this whole thing, the blood is being filtered, it's feeding the kidneys, and it comes back into the into venous circulation. Yeehaw. Yes. So, your kidneys can do a whole lot with not a lot of nephrons. However, as we'll see in chronic CKD, once you reach that 90 to 95% of nephrons destroyed, now we're looking at an issue. Now the kidneys cannot operate as effectively as they may have wanted to operate, which is a bummer. We don't like that, but hey, in these dark days, you got to do what you got to do, and your kidneys are troopers. They will work until they cannot possibly work anymore, and then they'll start to fail. But an acute kidney failure, where this is usually caused by straight up, now we're not getting blood. That's the same thing as you're not breathing. If you're not breathing, you're going to die pretty quick, okay? If your kidneys aren't getting blood, right, they're going to die pretty quick. It's the same concept. They need that oxygen for their cells to be able to use aerobic respiration, okay? Because aerobic, literally, they have oxygen. If they don't have oxygen, they can only do anaerobic respiration for like a couple minutes, and there's only so much oxygen going around these days because let's just say there's not a whole lot of blood. There's not a whole lot of blood to carry oxygen, so you could be breathing a whole lot, and your red blood cells are doing their best. There's not a whole lot of fluid for those red blood cells to sit in, so no matter how much vasoconstriction you've got, there's only so much blood that's carrying oxygen, which sucks. So, in an acute kidney injury, that perfusion causes damage because of ischemia to the tissues. This is temporary, okay? If you were to get that fluid back, your kidneys would be like, oh, thank goodness, it's not more of a pathologic process in the kidney. It's just simply your kidneys can't breathe. Now, if you can't breathe because there's some sort of obstruction, once you get that obstruction out, everything is rocking and rolling. Yeehaw, what a great day, right? And it's a bit similar here. Now, if there was really long prolonged stuff that happened where the kidneys weren't getting a whole lot of oxygen at all, there's a chance that you could have like a lingering signs of injury, like those nephrons may never be the same. But at the end of the day, if you can get those kidneys back working, it's likely they'll continue to work for a good chunk of time. They might not just have the longevity that you may have had before the acute kidney injury. Now, it's got two kind of phases. The first phase and the injury phase is oliguria. Your body realizes, oh shoot, we don't have enough perfusion. We need to hold on to all the water we can. We need to hold on to all the freaking water, okay? Boom. So they will hold on to that water knowing that maybe that water is not going to be the cleanest, most fresh, most best. They want to hold on to that fluid. So you're going to have very concentrated urine. Your urine specific gravity is going to be like super, going to be like high. It's going to be very osmotic, right? You have this, it's full of concentrate because your kidneys are like, hold on to all that fluid. We need that. So you're going to have osmotic, low volumes of urine, okay? Now, let's say that, okay, perfect. Now you've got a good fluid volume. Everything is rocking and rolling. Well, now the kidneys are like, well, I'm glad that we've got fluid now, but look at all this waste that's built up in the meantime. We've got like cell debris waste. We've got waste of all these different things that we tried to do during the process of healing that we need to get rid of. So after that oliguria phase where you didn't pee a whole lot, now your kidneys are like, all right, let's get back on the money, people. Let's clean ourselves up, okay? It's kind of like after being really busy in school where you don't clean your room, you finish your last final and you look at your room and you say, this is an absolute disaster. We have to do something about this. But now you've got the time to do something about this because you don't have anything to stress about. Same deal here. Your kidneys are like, we've got the fluid volume we need, so now we can start doing all this cleaning that we've been waiting to do because we've been too focused on just keeping ourselves and the rest of the body alive. Yeehaw. Yeah, kidneys are they're just like me for real. Okay, I'm sorry. So that's an acute kidney injury. That's the bare bones basics of it. Chronic kidney disease, or ESRD, which stands for end-stage renal disease. Ah, yes. Condition where the kidneys have permanently lost most of their function and can no longer filter waste products from the blood. Yes, okay. End-stage renal disease. Yeehaw. So this one has a gradual onset, months to years. Now, you have to consider what things would cause a chronic kidney disease as what things would be a problem, perhaps a more insidious problem, where over a much longer time, things start to slowly go wrong in the kidneys. Let's look up some things because I could come up with them in my brain, and I'm sure we're going to talk about them later, but I would rather be sure that I know these ones. So, what kind of things would cause kidney disease? Diabetes, high blood pressure, and kidney infections. Yeehaw. All right. Yeehaw, people. Yeehaw. All right. So we'll go over why all those things cause chronic kidney disease in literally the next slide, actually. Look at that. But, actually, we can do it after this. Anyway, we talked about how the nephrons are really, really strong. They're powerful until you kill most of them. And then after you've lost 90 to 95% of them, the kidneys start not being able to actually get rid of waste product effectively. So that means that once you get to that last moment, okay, you might not realize, a person might not realize that they have that issue with their kidneys until they've already lost a lot of their function. In this case, they have here only once that amount of damage has happened will you see BUN and creatinine go up. Because blood urea nitrogen and creatinine, blood urea nitrogen is just how much nitrogenous waste has built up in the blood, which is, you can say, is due to the kidneys not being able to actually get rid of your ammonia and your urea. Creatinine is a waste product produced by muscle metabolism, filtered out of the blood by the kidneys and excreted in the urine. Wow, look at that mess. C4H7N3O, molar mass, lots, whatever. Okay. Creatinine is a byproduct of muscle energy production, released into the bloodstream at a constant rate proportional to muscle mass. So creatinine levels are measured in milligrams per deciliter, blah, blah, blah. Okay, elevated creatinine levels may indicate impaired kidney function. This is because the kidneys are not effectively filtering creatinine out of the blood. Other causes can be due to muscle breakdown in rhabdo, dehydration, and certain medications. La 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 la. All right. So that's creatinine. Still a waste product that has to do with how our muscles are being used. In the case of muscle breakdown, which can happen in the last stages of shock, your creatinine is going to be high, of course, because your muscles there will actually start to break down. Let's see. Muscle metabolism. Yeehaw. Product of muscle energy production. Crazy. So, yeah, look at that. Stages 1 to 5 are based on the glomerular filtration rate. CKD stages. Yeehaw. So there's our chronic kidney disease 5 stages. Now, I don't think we're going to be tested on these in the actual exam because this is kind of over our pay range, but it's kind of interesting to look at. The glomerular filtration rate is a measurement of how well our kidneys, because remember, the glomerulus is kind of like the mastermind behind the whole kidney operation. That's where the actual filtering of the blood happens. Now, if somebody's able to measure the glomerular filtration rate, they're able to determine how well the kidneys are actually filtering the blood, okay? Now, of course, the lower the glomerular filtration rate, the less waste is being cleaned from the blood, which means that's more waste products will be in the blood, which means that not only will that affect our other tissues and organs, but that will also affect the blood vessels, because the blood vessels don't like the waste either. It's waste for a reason. It causes problems and it makes us all feel, it gets us all toxic and nasty and can affect our cognition and overall well-being and muscle vascular stuff. So, Stage 1, normal kidney function, which is a GFR of over or equal to 90. Stage 2, you're looking at anything under 90 to 60. Stage 3, under 60 to 45. Stage 4, which is now we're in severe kidney disease, anything less than 30 to 15. And of course, under 15, you're looking at kidney failure, that kidney is not doing a whole lot. So in the early stages, there may be no symptoms because your kidneys are compensating. They're like, hey, that nephron just died, but don't worry, I'll pick up the slack. And your kidney's like, yay, woo, go kidney forever, until the nephrons all die. And then the ones that are left cannot possibly compensate for all the rest of the things that the body needed. Now, you do have 2 kidneys, which is awesome, right? Yay, woohoo. But, I mean, that's a really good question. If you have CKD, will that be in both kidneys? Yes. Dang it! That sucks. That's so funny. In some rare cases, might occur in one kidney while one is less affected. Yeah, and I mean, the thing is, the kind of things that are going to cause CKD are usually systemic anyway. Like we were talking about, like diabetes. Listen, diabetes is a problem that ransacks all your blood vessels, not just some for one kidney. High blood pressure, that's all throughout your body. Heart disease, that affects everything else in your body. Kidney infections, now that one might be more of, if anything, maybe like a one side only, but listen, your ureters go up both tracks. There's 2 tracks there, so whatever. Glomerulonephritis, which is inflammation of the glomerulus. Polycystic kidney disease, which is cysts in the kidneys. Kidney stones. Kidney stones might be a one-sided thing. Yeah, if it's like right in the adrenal medulla. Let me see if I... No! I deleted it! That hurts me so deeply. La la la. Calyx. Yeah, the calyxes. So much random junk. All right. But yeah, so if you've got a stone right up in there in your cortexes and calyxes, yeah, in your renal pelvis, if you've got anything up in there, that might affect one kidney more than the other. But that's an acute problem. Like, you don't have like a long term, I mean, unless you keep that kidney stone there for years. That sounds awful though. So, renal failure. Yay. Okay, so let's talk about the different types of things that can cause renal failure and where they're at. So there's 3 types of renal failure, okay? Pre-renal. Now let's think about words for a minute. I know it's hard to think about words because I don't like thinking about them either. It's been like 30 minutes and I haven't gotten to slide 3 of a lot. So let's just keep talking and hope that I finish someday at some time. Now, in a renal problem, this has to do mostly with blood circulation, okay? Anything that's trying to get to the kidney, okay? Now, does that mean that you might have hypovolemia? Yes, it could. Could it also mean that your blood vessels suck and can't move and distribute blood appropriately or get blood to move through them appropriately because they're all messed up and scarred because of long-term damages? Yes, of course. So, a pre-renal acute problem we talked about was hypovolemic shock. Yup. Yeehaw. That's it, baby. Boom. Because there's not enough blood getting to the kidneys. If you get enough blood to the kidneys, problem solved. Yeehaw. Okay. A more chronic issue would be diabetes, because that causes damages to the blood vessels themselves, causing them to be a lot more hard. It's a lot harder for things to get through. It causes long-term damage to those blood vessels, long-term damages to the tissues. You can see here that diabetes is an issue in both pre-renal and intrarenal, because that nasty sugar in the blood is also going to damage the actual organs of the kidneys themselves, just simply because there's too much sugar everywhere, which causes this strange inflammation to kind of build up everywhere. And if that blood is getting into the kidneys, it can cause that same inflammation in the kidneys, causing damage inside of them. So in pre-renal, it's mostly the actual damage to the blood vessels. In intrarenal, it's damage to the kidneys. But let's not get ahead of ourselves now. In heart failure, you can also have a pre-renal problem, because if you've got a really bad backup of blood in the heart, I mean, it's not really getting anywhere. You've got all that blood sitting in the heart, not moving, or being backed up into the venous system, and meanwhile your arteries are like, hey, hello, hey, where's our blood? Hey, did we think about where our blood is at? Hey, I'm not getting any blood. Heart failure is kind of tricky because I'm trying to place it in chronic versus acute, and I think depending on the onset of the problem and how long this heart failure has been going on, what the actual, in the short term, if you were to have an issue with perfusion related to heart failure, you could call it an acute problem. But if that issue has become so much of a problem that it's caused actual ischemia of the kidneys in the past, I guess you could call it more of a chronic thing. Which doesn't help much, but that's kind of where my brain is going. Overall, though, it has to do with the fact that, blood's not getting to the kidneys. Whether that's long-term, short-term, either you're slowly draining them of oxygen or just straight up putting a pillow over their nose. That's what's going on in pre-renal failure. Intrarenal, inside the kidneys. That's what that word means, okay? So we talked about how diabetes can cause that, because remember, having a lot of that sugar in your body causes everything to get inflamed. That's not fun and cool. So that happens in the kidneys, which causes damage to the tissues. Pyelonephritis. Okay. Now, pyelonephritis. That is an inflammation of, the nephron. I want to double check. Cat affects the kidney. Really? Oh, is it a urinary tract infection that affects the kidneys? No way. Enters the urinary tract and travels to the kidneys, causing inflammation and infection. Okay, gotcha. So pyelonephritis is UTI plus. The UTI plus. The UTI has become a super UTI. It's no longer just affecting the urethra. It's climbed its way up. It's traveled. It's dug its crusty fingernails all up and down your ureters, and now they finally made it to your kidney, which is not good. That's not good. Can cause kidney damage, sepsis, high blood pressure, which is not great because if your blood pressure is too high, it can lead to, of course, reduced oxygenation of the tissues and organs, causing damage. Yay, ischemia. Reduced kidney function and kidney scarring, which is not good either. Now, this pyelonephritis treated with antibiotics, which may need to be taken for several weeks. Most people with pyelonephritis don't have complications if treated appropriately. So you want to drink lots of fluids, empty your bladder completely, pee before and after having sex, practice good hygiene, shower regularly, blah, 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 blah. Blah, blah, blah. Okay. Basically, don't get a UTI, and if you get one, treat it. Go and get antibiotics, of course. Post-renal. Yay. So we've talked about pre, which is before the kidneys, intra, which is inside the kidneys. What about post? Because guess what? Your kidneys are the first in a long line of your urinary system. Yay. So that means in a post-renal problem, you have issues that stem from anywhere before your kidneys. That could be your urethra, your bladder, your ureters. Yay. Bladder distension, prostate blockage, kidney stones. They have a table in the book for causes, which I guess we can open up. That's so funny. Well, I guess you're just going to have to hear me talk as I drop my pens all over the floor in the attempt to grab my med-surg textbook. Okay, we've got the med-surg textbook. Moving the microphone. Now we have to go in the index and figure out where we're going here. Hello, where are we? Trauma nursing. Vascular problems. That's not it. Gastrointestinal. Intestinal. They have one for GI, endocrine, reproductive, renal, and urinary system. Yay! Oh, how fun. Kidney disorders. Oh, look at that. So we're going to go to 1,355. 1,355. La, la, la. Dang, that's like a really far away from here. So here I am, just trying to figure out where the frick, this dang table is. Oh my goodness. Sorry, I just saw a polycystic kidney. That kind of rocked my world. I'm gonna polycystic kidney. Ooh! What the frick, dude? Oh my goodness! Well. Genetic disorder characterized by the growth of numerous fluid-filled cysts in the kidneys. Gradually enlarge and can damage them, leading to progressive loss. Wow, that's so rough. But that's a genetic thing. Wow. So I still have not found, this this table of causes of this people we're talking about. Okay, so I'm just gonna keep on looking. I'm just gonna keep on looking. They have stuff. I have a table about incontinence. I have an incontinence table, but they don't have anything else. They have older adult considerations. They go over the anatomy, which is cool, but that's what we've just done. Okay, well, you know what? I can't find this dang table. So I'm just gonna say that we know, okay? Issue here to there causes damage here. Yay. At the end of the day, where this happened, pre-renal, intrarenal, and post-renal, that's all it is. We know that somewhere, coming from some place, something has caused damage to the kidneys, okay? And if we know where it's at, right? I mean, if you're talking to a physician, they want to know where it's at so they can know what to, where to look to treat it. As our job as a nurse, it's really just we have to understand maybe what's going on so that we can understand where the doctor's coming from. It's just kind of fun to know. This is really just extra info for fun. That's all I do this for, is for fun. There's no reason, okay? There's some patient education, but at the end of the day, when it comes to stuff like, the course of their treatment and disease, that's more of a doctor's scope of practice. Once the doctor leaves, we should be able to answer questions, but we can't answer all the questions because we're just nurses. That's all we are. Diagnosis. I'm starting to get that raw throat feeling. All right. BUN and creatinine. These are our two big chunkers for kidney disease. Now, we did talk about how, unfortunately, in chronic kidney disease, we may not see these become elevated until we're in one of our later stages, okay? Creatinine, they have that one big. I have that highlighted because creatinine is our best blood test to measure how kidneys are doing. But, of course, you can lose up to 90% of nephrons before this rises in chronic kidney disease. Now, if you're having like a systemic issue where there's muscle wasting all over, or not muscle wasting, muscle use and damage all over the place, yeah, your creatinine is going to raise. Let's say, you are going into rhabdomyolysis, your muscles are dying, breaking apart, exploding. Your kidney can't keep up with all that. And, it's damaging your kidney as well, all that junk that's flowing through them. So, in general, though, if you've got like just basic kidney disease, chronic kidney disease, it'll take a while for your BUN and creatinine to raise because your kidneys are like, don't worry, I got this. Your kidneys need to learn how to ask for help. That's what I've learned. All right, kidney biomarkers. This is a new kind of cool thing that they're doing to help to predict if you're going to have kidney disease. TIMP2 and IGFBP7, which are really fancy things that I am like 91% sure they will not care about on the test. Okay? I guess the question is it having them? Substances that indicate kidney function and health. So if they've got these nasty things, what the frick? They have these as biomarkers. KIM1, ADMA, NAGL. Where the freak is IGFBP? Insulin-like growth factor binding protein? What the sigma? Okay. Heart failure. Here we report that cardiac and blood expression of that is robustly increased in patients with chronic heart failure in the mouse model. Yum. In a pressure overloaded mouse model, deficiency attenuated cardiac dysfunction. Okay, what about kidneys, baby? Because, cardiac senescence by stimulating all of that. La 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 la. Consequently, selectively targeting that may have a broad therapeutic potential for heart failure. Okay. This is all about heart failure. What the heck are they talking about? Involved in directing cell growth, protein acting in the lining of blood vessels. Okay, so I guess they could use that one, and if somebody's got some sort of weird insulin-like growth factor binding protein 7 helps stop a pathway which is involved in directing cell growth. Vascular endothelium. A single gene mutation with retinal arterial macroaneurysm. Okay, here guys, we finally found it. In the case that this gene has a mutation, then you can get a macroaneurysm, which aneurysm, that's a much bigger aneurysm than it sounds like. Let me check here. Retinal, but that's just retinal. Guys, I'm stupid. It's in the eye. Guys, this is the dumbest crap I ever seen. What are we talking about here, guys? To control BRAF signaling? Unknown how this increase is related to specific blood vessel abnormalities. Confirmed to the eyes and pulmonary artery. What? Do they even know what they're talking about? Kidneys. Okay, here we go. Here we freaking go. Look at this, guys. We finally found it. Here we go. Predict different types of acute kidney injury and has drawn significant attention as a urinary biomarker. It's unclear whether it acts as a key regulator and if its mechanisms underlying its upregulation still need to be determined. Highly expressed in the blood and urine of patients in mice, possibly with blah blah blah. Positively correlated with kidney dysfunction. Oh my goodness. Overactivation of that axis represents a promising target for an AKI treatment. Well. And I'm sure that this other one is going to be really, really similar. Protein that helps regulate the kidney's extracellular matrix. Levels increase in the urine when kidneys are damaged, and it's used as a biomarker to help predict acute kidney injury. Here's the thing. That's kind of funny. They have these kidney biomarkers. It's like they look for them, and they're like, hey, guys, it looks like the kidney's not working. Which is the thing. Like, that could be really helpful in a case of, like, but this isn't an acute kidney injury to help predict. Okay. I feel like the other one with chronic, or was the other one even chronic kidney disease? They're both acute. Okay. When the kidney is under threat for any reason, when there's a question of secondary nephrotoxicity, there's a significant change in status that might result in a kidney injury. So I guess when they're like, maybe there's a kidney injury here, let's look for the biomarkers. Okay, makes sense. Urinalysis. Urinalysis. They're looking for microalbumin. Now, this is important, okay? This is actually really important. Proteins should not be in the urine. Now, ammonia, which is a protein byproduct, waste product, can be totally in the urine, 100%. It can 100% be in the urine. Yeehaw. But proteins, thick, chunky proteins, should not be in the urine, by the way. They should not. Okay? Albumin, Microalbumin, in fact, they should be too big to get through the glomerulus. They should be too big. But no, in a course where there's been damage to that area, there's been damage to those blood vessels, bigger things can slip through, like, and not limited to, proteins in blood. Red blood cells and proteins should not be able to get through the glomerulus in normal circumstances. When you're peeing blood, when there's blood in the urine, when there's protein in the urine, there's an issue, okay? Great. In a urinalysis, if they find proteins, that's not good. That's bad. Ugh. Why might... Oh my goodness. What... La la la. Okay, I'm glad they say when your kidneys aren't working correctly. Damaged kidney filters allow proteins to leak. Damages can damage kidney blood vessels, causing them to leak. It's just leaking. There's a hole in the glomerulus. It's like, I just can't stop the protein from slipping in. Yeah. Because the glomerulus, as far as I can remember, they also use everything freaking uses a pressure gradient. Let's be real. But the pressure gradient is really, really nice. Like it's a much lower pressure there. So anything that can fit wants to go into there for the glomerulus to say, all right, let's get through here. Let's decide which ones of these we want to, which ions we want to hold on to, which ones we don't, blah, blah, blah. But if there's a damage, right, there's still a low pressure gradient on the other side of the glomerulus. So those bigger things are like, ooh, that sounds nice. What do you mean? Less pressure? Thank you very much. So they slip right in, and now we've got an issue. Anyway. La 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 la. Okay. Creatinine clearance. Creatinine clearance. How is that different from a normal... It's probably how much is being gotten rid of. Okay, how well your kidneys are functioning compared to the level of creatinine in your blood to the level of creatinine in the urine. Oh, I'm sorry. So, they decide, okay, well, how well is the kidneys getting that creatinine out? CRCL, creatinine clearance. Gotcha. Yeehaw. Okay. Glomerular filtration rate. We talked about that a little bit. Normal. Anything over 60. So I think we talked about how 60 is like stage 4. Or no, stage 2. Yeah. So at stages 1 to 2 of chronic kidney disease or whatever, right? Those you're probably okay. Like you're not going to lose anything yet. Those are within normal ranges. Anything under 60 as far as a glomerular filtration rate is concerned, that's not good. That's bad. That's bad, as the kids would say. We don't want a glomerular filtration rate less than 60 units per hour. Yeehaw. But if they're looking for this, they can kind of see what your glomerular filtration rate is looking at, trends or whatever. Renal ultrasound, CT scan, MRI. I think that's also looking for like scarring or maybe even those like weird fluid cysts. Those were crazy. A renal arteriogram to see what the vessels look like that are feeding your kidneys. Because if those are all wrecked, scarred, and destroyed and full of nasty gunk, then maybe it's not going to be crazy to see why that wouldn't be the best way to feed our kidneys blood through those nasty arteries. Kidney biopsy. They take a part of your kidney out and look at it. Just like in the liver. They go... And, of course, with your kidney biopsy... You're going to have the same things you're worrying about after like a liver biopsy, so mostly just bleeding. In the first 2 to 6 hours after the biopsy, that's when you're going to be most likely to have that bleeding problem. So, we want to be monitoring for bleeding, but we also want the patient to lay on the side. This is important. You want to have them lay on the side that they got the biopsy on. Why would I want to do that? That sounds like it would hurt. The thing is, right, when you have somebody bleeding, the first thing you want to do is put pressure on the wound to help press down on those broken, messed up blood vessels to possibly help the clotting. Okay? Now, if this person is bleeding, wouldn't we rather have them have pressure from laying their body weight on the side that had the wound, the injury, so we can compress those blood vessels and help that area to heal and not bleed that person bleed out? Great. Yeah, sounds like a plan to me. And we talked about bleeding in the sign of your liver, Turner sign, maybe colon sign. Here, we're basically going to be looking at Turner sign, any sort of blood in the flank or whatever. Systemic complications in renal disease. Wow. So, waste products. Anytime there's waste product buildup in the blood, your body does not like it. Okay? It's not good for your brain. It's not good for your organs. It's not good for your blood vessels. Everywhere the waste touches, the body is like, what the frick is this doing here? It's literally ruining my vibe. That's what's going on. So, you're going to see all sorts of issues in the body in renal disease. Yeehaw. Okay. So, neurologic issues. So we just talked about this. We just talked about how an increase of waste products, okay, in the blood can cause this nasty thing right here. Hold on. La la la. Look at that, people. High ammonia can lead to brain swelling, which, of course, is going to increase our ICP. Duh. That's so rough. Oh, well. That's not good, people. Oopsie. So, neurologic can cause increased ICP. I'm sure there's other reasons. Why can renal disease, oh my word, cause increased ICP? Of course, accumulation of waste product. Oh, so it literally just is that. What the frick? Hey, at least we got it right, people. At least we got it right. Accumulation of waste products that causes an increased ICP. Because, and this is like a weird thing where it has to do with the osmolality of the blood. If there's a bunch of crap in your blood, your brain looks at that and goes, where's our fluid? We need fluid. Give us some fluid. So the rest of your body's like, oh, okay, here, you can take our fluid. And it causes this swelling in the brain, not necessarily due to the waste products itself, but because the brain is like, hey, this is nasty. Can we actually have some fluid in here, please? And so they dump fluid into the brain, maybe not in other places, right? So now other places don't have a lot. But the brain, they directly divert, fluid to the brain, which the brain is like, oh, finally, right? Because there needs to be an osmosis that occurs to create balance, okay? There's so many different products, okay? Like, there's, what is the freaking word? There's more solvents than solution. It's been a while since I've had to deal with that crap. But the idea and concept is the same, right? There's a bunch more products in this side than this side. So the extra water from this side is going to say, well, we don't need as much water to balance out the stuff, okay, in this side. So we're going to just go on to the other side, which causes brain swelling. We don't like brain swelling. It's not good for our brain. Long term, that makes our brain very uncomfortable. and can lead to pressure in parts of the brain we don't like to have. More people be texting me. That makes sense. All right, back to it. Cardiovascular. It causes hypertension. Oh, why does it cause hypertension? Why would this cause problems? Okay, here's the problem, people. You know, I've always thought that the body's, like, the body's opinion of potassium is very interesting. Potassium is, like, one of our most important electrolytes. Let's just be real. If your potassium is too high, dysrhythmias. If your potassium is too low, dysrhythmias. We need potassium. But you know what the first thing to freaking go is when we start losing fluid volume? Potassium. Aldosterone looks at potassium and goes, you know what you are to me? Dirt. Nothing in my heart. I hate you. And potassium goes, what? And then you get rid of potassium. Mass excretion of potassium. Well, that's great. I'm glad that we got rid of all of our potassium. That's a super awesome idea. I'm so glad we did this. Now, if your kidneys aren't working, they really can't get rid of anything. They're really bad at everything, truly and honestly. So they can't get rid of potassium in the way that they would want to get rid of potassium. So that potassium just builds up like crazy and can lead to dysrhythmias. It can lead to dysrhythmias, people. Ventricular tachycardia. Not good. That's a bad one, guys. It's a shockable rhythm, yes. It's a bad one, though. We don't like it. How does it cause hypertension? Well, it's not really able to regulate fluid volume at all. Like, if you happen to have a lot of fluid volume, it wouldn't be able to really, like, get rid of it. And, I want to see if there's not any other reason why hypertension in renal disease. Of course, they have difficulty excreting sodium, leading to fluid retention, and they can't compensate for it because they are the compensation. What the Now, this is so interesting. This is truly interesting because the renin-angiotensin-aldosterone system wastes potassium. It literally wastes potassium. That's the whole point of it. Hold on. Why hyperkalemia in renal disease? Sure, renal failure works. Kidneys can't remove enough potassium in your body. They just can't remove it at all. If RAAS is going. Despite the system attempting to compensate by promoting potassium excretion through aldosterone, damaged kidneys are simply unable. So they just literally can't. That's so embarrassing. That's so embarrassing. So, hold on. Not only can they not get rid of sodium, even though the renin-angiotensin-aldosterone system is like, hey, wake up! They can't get rid of potassium. So they're in double trouble because sodium, we got low sodium, that's not good. Low sodium, we're looking at seizures. High sodium, we're looking at hypertension, which is it's not good for our tissues either, because if we get too much hypertension, our tissues aren't getting any oxygen. That blood's going too fast. It can't grab oxygen. It's like being in one of those like money grabber things where there's like a big vacuum, like a bunch of air up in that area, and it's like grab as many dollar bills as you can. Well, you can't grab that many because the air is moving it around so much. That's your organs trying to grab oxygen when you've got high blood pressure, like really high blood pressure, not just, oh, well, my blood pressure was kind of 135 over like 93. Like, great, you know, it's a little high, but you're not going to die. We're talking hypertensive crisis problem here, which could be made worse if you've already got like issues with your blood vessels due to diabetes. heart failure. Ooh. And then respiratory, shortness of breath, crackles in lungs, which has to do with fluid volume overload because you can't pee out your fluid very well. Ooh. Integumentary. Okay, so when you've got gunk in your blood and your kidneys aren't working, what does your body want to do? Well, it looks at your skin. It looks at your beautiful, healthy-looking skin, and it says, hey, we can secrete stuff out of that, right? And the blood vessels go, I guess, and it goes, perfect. So it takes all of those, oh my goodness, those exocrine glands? Yeah, exocrine glands. Yeehaw. Yeehaw, baby. I want to check that. I think it's like of glands are sweat glands. Sure. I'm so good at this. Those were the two I was looking at. Eccrine and apocrine. Yeah. Apocrine, they smell like crap. Eccrine, they're cute and beautiful. Now, here's the thing, right? If you are secreting waste, If you are secreting waste out of your skin, that's not going to be a pretty smell. Let's be real, people. That's not going to be a pretty smell. You know how your pee smells? Hey, let's be real. Hey, let's just get this off of our chests, okay? You might also have edema because of fluid volume excess. Pretty elementary. And then, look at this. Uremic frost. Wow. Now, uremic frost is actually not cool and fun. This is your body desperately trying to get the freaking salt out of your body by putting it on the up... trying to get rid of all that crap in your body by making it into crystals and dumping it outside of your skin. And it's very itchy. White crystalline deposits on skin. Yikes. Yeah, that's not fun. It's really, really itchy. All I can think of is those poor little pores, like crystals just kind of like dumping out of them. What the frick? Uremic frost involving left buccal mucosa? Oh my word! Uremic stomatitis? That's so rough. So your body essentially looks at, oh my word. Your body looks at any sort of exocrine gland and goes, okay, baby, it's time to get rid of this waste. Kidneys aren't doing it for us, so we gotta do it. Oh, that is so rough. Oh, that is not cool. That is not good. Oh, what the frick? Renal itch, uremic pruritus. Makes sense. Because your body is trying to get rid of all of its waste. And your poor skin is like, hello? This feels awful. I hate this. This is the worst. This feels not good at all. I hate all of this. And of course, itchiness, pruritus. Oh, and look at all those lab changes. Ugh. Well. Now, electrolytes. We talked a bit about some of these so far. You know, how you're going to have increased potassium, increased sodium, decreased calcium, increased phosphorus, but we kind of said and magnesium is there too. Okay, so magnesium you're also gonna hold on to because why not? The only reason, okay, that calcium is low is because you really can't get calcium until you get the special calcium absorber from the kidneys, which you don't have in kidney disease. Bummer. So you lose your magnesium. So the reason I have stuff there is that like Milk Mag, antacids, laxatives, those have magnesium in them. They increase magnesium in the blood. So, if a person has chronic kidney disease, you're going to want to look at somebody who has that on their MR and be like, that's interesting. Because they already have, or they may already be at risk for having a high magnesium level. So, if they've already got a high mag, you want to be like, hey, maybe call the provider who signed the order and say, hey, you sure you want to give this to them? They've already got a high magnesium. It might just be risk versus reward, which, hey, in that case, I'll take it. I don't mind. That's fine. But, like, at the end of the day, I want to make sure that, like, the patient's not going to be in danger. So magnesium, having, like, a low magnesium is more of a painful thing, but having a high magnesium can cause, like, muscle flaccidity and, like, safety issues. It can also cause heart stuff, right? High magnesium symptoms. Muscle weakness, nausea, vomiting, diarrhea, flushing, headache, and dizziness. Cool. Low blood pressure, slow heart rate, decreased reflexes, confusion, urinary retention. Oh, respiratory depression. That's cool. And cardiac arrest. Because, yeah, your magnesium is, like, so high, it's like, hey, buddy, why don't you just go to sleep? Just go to sleep. Oh, who are they whispering to? The heart? Yeah. They're going, hey, buddy, what if you just didn't do anything? Yeah. Go to sleep. Okay, that's terrible. But yeah, we don't want a super duper high mag. I have written here, calcium and phosphorus won't change much in acute kidney injury because, yes, we talked about how calcium and that absorption of it, that's more of a long-term thing that's going to cause that renal osteodystrophy. Yeah. And phosphorus goes along with calcium. So if calcium is high, potassium's low. What the frick? If calcium is high, phosphorus is low. If calcium is low, phosphorus is high. So in the case that your kidneys aren't working to help your body to grab all the calcium it can, phosphorus is going to say, hey, it's my time to shine. And why is that? I'm curious. Why does phosphorus increase when calcium decreases? Phosphate binds to calcium. Of course. That's so embarrassing. Tightly regulates calcium and phosphate to maintain muscle function, during communication, and bone formation. Oh, those are kind of important things, don't you think? So that's really accurate. Wow. Typical Western diet contains more phosphorus than calcium. Too much phosphorus can cause the bodies to use calcium from bones. Oh. Great. Anyway, that's a whole nother deal. These guys are more chronic. These guys are going to be more acute. Mostly just these guys, for sure. And Mag is there as well. Don't worry about him. Don't, yeah. Go to sleep. Okay. Uric acid. We talked about that already. Platelets. Okay, now this is an interesting one. Because you might be wondering, well, what does this have to do with, like, blood making? Okay, so here's one thing. There's two reasons why you might have lower platelets. Okay? There's a couple of reasons. We'll start with the first one, okay? If you've got chronic kidney problems, the waste products in the blood are going to impact your platelets' ability to clot and stick together. Which, okay. I don't care if they can't clot, but you might have normal platelets. Hold on. Why are platelets low in CKD? Directly impair platelet function and lead to decreased platelet production, called uremic thrombocytopathy. Thrombic cytopathy. Cool. Primarily because damaged kidneys are unable to filter waste products from the blood, using a buildup of substance that negatively affect platelet activity aggregation. Okay, so basically it is just the fact that not only do they not want you to make platelets when you have CKD, like your body just doesn't make them very well, but also they can't stick together very well. So the platelets that you do have don't have a very good clotting time, I would say. It probably sucks. Because the whole reason that platelets work, hold on. What part of the clotting cascade is affected by CKD? Okay, they can't clear out certain clotting factors, leading to an increased level of procoagulant. What the frick? What? Elevated fibrinogen levels? Oh! What? Clear out natural, antithrombin. What the frick? Impaired platelet function can further contribute to abnormal clotting. Well, that's nice. Oh, what a fun time. So you're telling me that we can't clot when we need to, and so we're just clotting. That's so stupid. Increased levels of fibrinogen. That sucks. That's not good. Fibrinogen to fibrin. It's really awkward. That's interesting. Okay. However, it says your platelets can decrease. So it's like, how does it can increase clot strain and a higher risk of thrombosis? Okay. Am I at risk for bleeding with chronic kidney disease? Yes. Oh my goodness. Platelet dysfunction. So, even if I have high fibrinogen, okay, this is due to a number of factors, including platelet dysfunction, impaired fibrinolysis, and alterations in the coagulation cascade. Okay, which ones though? Increased fibrinogen levels that can lead to increased clot strength. However, it can also lead to delayed clot formation and decreased clot breakdown. Well, that sucks. Have dysfunctional platelets can lead to abnormal interactions. So hold on. We can create clots, but we can't, stick to things. This is just so dumb. Bleeding can occur in weird places. Not only do patients have a higher prevalence of angiodysplasia, what the frick? Abnormal, dilated, twisted, nasty blood vessels in the whatever. Okie dokie. Angiodysplasia is the leading cause of recurrent bleeding. What would cause bleeding from the kidneys? Well, that's not what we're looking for. Okay, platelets. Listen, if somebody's got low platelets, they won't clot very well. What I'm hearing here is that issues with the actual way that the platelets stick to things can cause sort of, the body desperately wants to clot, it just can't clot very well. And when it can, it's usually not in the right place at the right time. Okay, GFR I have here, it's lower, of course. Doesn't change with dialysis. Oh yeah, we'll talk about dialysis in a second. Iron will be lower because it might be getting folic acid. What the may be getting folic acid okay, what the frick? In kidney disease. La la la. Folic acids may be elevated in the blood due to impaired ability of the kidneys to filter out folate, even if dietary intake is normal. While sodium folate levels may appear high, may be considered folate deficient at the cellular level. Wow. So they don't have good iron, but they got plenty of folate. That's so stupid. Or folic acid. That's so silly. Because we can't utilize folate. Oh my goodness. Why can't we utilize folate? disease. Guys, we are on 8 of 18, okay? Kidneys play a crucial role in folate metabolism by filtering and reabsorbing it, and if impaired, can lead to potential folate accumulation, which can be harmful. That sucks. Body can't effectively excrete folate, leading to potential buildup, which can become toxic. Bad. Too much folic acid. Might harm. Shut up. High folate levels. Okay, symptoms. Do not usually cause any symptoms, but very high levels may lead to nausea, diarrhea, skin rash, and seizures. Oh, cool. I love seizures. Just kidding, that's not funny or true. Red blood cells. Okay, because red blood cells are created both due to the stimulation of erythropoietin as a hormone released by the kidneys, but also in the bone marrow. And if we don't have calcium that's making the bones happy and healthy, they can't actually work very well to make red blood cells. Awkward. Hemoglobin, same problem. BUN, high. Creatinine, high. Vitamin D, probably low. Urinalysis, might show proteins and blood into kidney, blah, 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 in the urine. Okay. Boom. Priority nursing interventions. Okay, these are not in order. These are not in order. Overall, our biggest priority for kidney disease is making sure fluid and electrolyte balance is okay. Okay? We need to make sure that our fluid volume is cool and awesome. Yay! And that we are not in like a super, super crazy electrolyte, problem. Like if we've got an insanely high sodium and an insanely high potassium, those are not good things. Let's get that potassium lower. Thank you very much. Now, there's a lot of things that dialysis can do for this, because dialysis basically works as our kidneys wish they could, based on what the doctor prescribes as their dialysate, which is this special fluid that pulls out exactly the things that our body should normally want to pull out. So usually our body's like, well, we want this, and so we'll take this out. But now, instead of your body doing it, it's a physician looking at your labs and saying, well, we don't need this, we will need this. And so then during dialysis, it just takes out all the stuff your body doesn't want. And it goes into the dialysate, which is dialysis pee. Cool. Anyway, we'll talk about that a little bit more later. But overall, we need to be maintaining good cardiac output. That's a huge one, okay? We are worrying about fluid volume overload for these patients because they're not able to effectively get out as much urine as we would perhaps like them to. So, yeah. I have here holding meds before dialysis, specifically the things affecting cardiac output, because we don't want them acting during dialysis and they'll be filtered out anyway. The reason that's the case is because we're taking off a lot of fluid on these people. We don't want them to have an opposite problem where we put so much pressure on the heart with these medications, cause the heart to beat like super duper fast, but now we've got less volume than the heart is used to pumping, and so now we have this hypovolemia problem that we created on our own. So good cardiac output must be maintained no matter how much fluid is in there, especially during dialysis. Monitor for pulmonary edema. Of course, we want to be making sure that this circulation issue doesn't become a breathing issue. Let's not move up the realm in safety ABCs. Acid-base balance, of course, we want to be making sure that, we're watching for those signs and symptoms. If this person's unable to do stuff correctly with their kidneys, let's say they're not able to get out that nitrogenous bases, okay? Whatever. Ammonia is NH3. That's 3 hydrogens. Okay. 3 of them. That's a lot of hydrogens. Hydrogens in and of themselves are acidic. Like that's an acidic deal. And if our kidneys aren't working to get out those waste products, we might be looking at a potential metabolic acidosis problem. This won't happen in like a day, but it could happen in like 3 or 4 days or a couple of weeks if this isn't kept on top of. Sorry, I'm being texted again. Okay, we made it again. Risk for infection, that could be if they've got, if they are going into dialysis, we're worrying about the fact that we have to, like, get into their bloodstream with either, like, a dialysis catheter, like a 2-port kind of deal, or a fistula, both of which, like, we would rather not have be infected because that, like, directly touches their blood. So that could be awkward if that turns to sepsis. So we want to make sure they don't get infected. Also, that leads also to, like, a UTI. That sounds like it would not be good for them. Risk for impaired skin integrity. I mean, if they've got those uric acid crystals, that could be a part of that. But also, if they're getting this dialysis thing and you're interacting with their skin, yeah. And then minimizing fatigue. Because these people will be tired. They've all got these waste products all up in them. So, not cool. This is a case study. They have these hyperkalemia treatment. I would rather go to Canvas and pull up what they put there, because that was a really chill one. That had a great little thing. La 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 la, la 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 la, la la la. Where am I even looking? There it is. Okay, treatment. Look at this. So for potassium being high, there's a couple of things we can do. We can give them sodium. Well, the physician will do this, but we need to know what this is for. Sodium polystyrene sulfonate, also called Calexlate. I spelled it super wrong. Which can be given orally through a retention enema. Which, boy. What the? Okay. Increases fecal potassium excretion through binding of potassium in the lumen of the gastrointestinal tract. Cool. That's really awesome. So that's one way we can get rid of it. Another way is through IV insulin and dextrose, because it promotes the movement of potassium into cells. You remember how insulin can sometimes lead to a decreased potassium level? That means that the potassium is moving back into the cells. Yay. IV calcium gluconate with cardiac toxicity. Well, IV calcium gluconate could also do it. Is a calcium salt to replete serum calcium levels? What the frick? I don't know. Okay. For hyperkalemia. Was found to be affected, albeit to a limited degree, in main rhythm ECG disorders due to hyperkalemia. So basically, if they're in a dysrhythmia, this person might receive IV calcium gluconate. So if they're having cardiac toxicity because of this potassium issue, calcium gluconate might be given. Otherwise, if they're not there yet, it probably won't be that effective. Cool. And of course, dialysis, because then the physician can look at their super high potassium level and say, well, we don't need that. Let's take some of that out with our dialysate. Wow. And then bicarb IV, for severe acidosis. Remember, you're like IV bicarb will probably not be given until that that pH level is like 7. Okay, like dangerously low. Because the last thing we want to do is shoot them into any sort of alkalosis by being like, ha ha ha, bicarb moment. Yeah, their pH was like 7.29, and now, bam, it shot up to way more than it should be. So, cool. Associated with acidosis and bleeding, blah, blah, blah. Metabolic acidosis common. Okay, cool. All right, that's how we treat hyperkalemia, or how a physician will treat it, and we just need to know what these things do for the test. Yeah. For the freaking test. And then here's our hemodialysis cath, but we'll go over that in a sec. So calcium, normal levels of calcium for treatments. If we have, okay, let's talk about sodium next, because those are the ones that are going to be increased, like in acute problems. You can get rid of sodium with loop diuretics, because where the water goes, where the sodium goes, the water goes, and blah, blah, blah. Dialysis will help. You can also give them fluid and sodium restrictions. And this is important. Fluid restriction when it comes to, like, acute and like kidney disease is based on the person's output. So in general, the way that they'll calculate a fluid restriction is 500 milliliters plus that person's output for the previous 24 hours. So if you peed like 600 milliliters, then your fluid restriction for the next day would be 1100 milliliters for the whole day. Is how much you can drink. They have 600 here. They told us 500. So what the skibbity, basically, is all I can say. Let's look. Huh? Oh my goodness. To 4 cups, 8 ounces per cup. Well, we can figure that out pretty quickly. 30 milliliters in an ounce times 8 per cup times 4. That's kind of a lot. 960? That's a lot more. Eight ounces, yeah, and 1 ounce it's 30 milliliters, right? Unless I'm stupid. I do know what I'm freaking talking about. Thank goodness. Okay. Anyways, plus 6, you know what? If they ask, I hate that. I hate that. I hate that. This is so annoying. Fluid restriction 101. Okay. So it looks like here is 500. There it's 600. For other people, it's like, well, if you just take 960 milliliters because it's 4 cups of whatever. Okay. You know what? Hemodialysis catheter. There it is. Don't draw anything from these. Don't even think about it. These are for dialysis only. Don't look at them. Don't touch them. Definitely don't pull them. Because this goes directly, that one goes directly into the SVC. Hey, did you know that? Did you know it goes directly into the SVC? So how about we don't freaking do that? Or is that a jugular vein? I don't know. How about we check? How about we freaking check? Where does a hemo go? How about that? Large vein. Yep, okay. Jugular vein is common. Okay, so it's jugular. Started to a vein in the center of the chest. Okay, well, that one would be the superior vena cava, and then, or it could be the femoral. groin to the top of the thigh. What the frick is that called? In leg. What's it called? Huh? What the freak is it called, dude? What is the vein called? Femoral vein. Didn't I say that? Didn't I? Okay, anyway. It's double lumen because see how there's holes on the one side and holes on the other side? Yeah. Anyway. You can also get a little one in your AV. It's not like a catheter, but it's like 2 needles. One that goes into the vein, one that goes into the artery, kinda. And then they draw the dialysis off of that. And you can also get fistulas. Now, fistulas are kind of wild and wacky. That's where you've got somebody, you take, essentially a doctor will go in, a surgeon will go in, take their artery, connect it to a vein, or like make a connection so that somebody can just really easily know, okay, let's connect the dialysis machine to this artery in this vein, because it works as the kidneys, right? Because the kidneys take the oxygenated blood, filter it out, pump it back in, okay? Now, the reason that these fistulas can get kind of big is because there's a lot of pressure, right, in this one area, which can cause those veins and artery deal to become distended. Don't worry, those bubbles are part of the screen, not the person. So you can see that distension in that AV fistula. Okay. Now, this is a PRISMA or a CCRT, which stands for continuous renal replacement therapy. Now, this is for like somebody in the ICU who basically needs constant dialysis, because if they don't get constant dialysis, their kidneys aren't going to work at all. Like, their kidneys don't work at all. They need this dialyzer to be their kidneys, which is really awkward for them. But yeah. It's very slow dialysis. This other type of dialysis can happen in like 3 hours, such, plus or minus. This guy is a lot slower. It's meant to basically be a kidney. And this is going to be more used in an acute kidney injury, where like you just need something to work right now on the kidneys to keep the person from dying from all the crap that's being built up in their body. Now, one thing you got to think about post-hemodialysis is what if there was too much taken off, okay? Usually in your body there's checks and balances, like your body's not going to get rid of too much. Like in a homeostatic process, let's say the renin-angiotensin aldosterone system's kind of getting out of hand, and the body knows it's getting rid of too much potassium. The heart's going to be like, hey, I need some of that, you know? Like, I desperately need some of that. And besides, I've got too much fluid. I've got so much fluid, I don't even know what to do with it. The body's fine, so it'll be like, hey, can you chillax? And so then it'll stop that from keeping on going. I think that's done by, oh, goodness freak. What is it done by? It's beta. Ugh. Oh my goodness. What the freak is it called? What does the heart release to slow the RAAS syndrome? Yes, natriuretic peptides. Atrial natriuretic peptide. That's what it is. See, I knew it. I just didn't know the name of it. What an idiot I am. Anyway, atrial natriuretic peptide that goes, hey, A and P. Okay. Anyway, it goes and it says, hey, chillax. And then the kidneys go, hey, you're the boss, and stop getting all that fluid retention and getting rid of potassium. And instead, atrial natriuretic peptides, like, get rid of the sodium and then take some fluid with it, okay? We don't care. But here, in hemodialysis, something might go wrong. And there the body's kind of just like, oh, well, we don't really have kidneys that work very much anymore, so the slow process of compensation is a little bit, well, it's a little bit more complicated. This person who went through dialysis might have hypovolemia because you took off too much fluid and now they don't have stuff, which is bad because that can contribute to a worse kidney injury. But disequilibrium syndrome. Okay, what is this? Disequilibrium syndrome. You know how we were talking about ICP that gets increased because of osmolality differences? Well, that is, in general, that is what causes disequilibrium syndrome, okay? So, what happens here, okay, and this is a little bit different than what we talked about, but it's the same idea, okay? In disequilibrium syndrome, let's say you've just had dialysis, okay? The blood-brain barrier causes things to shift slower, okay? So, there might still be high electrolyte concentrations in the brain after dialysis is over, okay? So dialysis is taking out overall systemic electrolyte imbalances, but because stuff moves across the blood-brain barrier slower, there's still extra electrolytes chilling out in the brain. And so the body looks at that and goes, "Oh, hold on a second. That doesn't fit our balance." So they shunt fluid all up in the brain to help to create more of a diffuse balance, right? Right? You know how in oh my goodness, osmosis, right? They have to pass a barrier or whatever, and then the solutes. Oh goodness. The fluid shifts over to where there's more solutes, I think, okay? So that there's a balance. We love balance. There needs to be a ratio, an equal ratio between fluids and the gunk inside the fluids all over the body. Well, unfortunately, all this fluid has shifted directly to the brain, which causes much more pressure to build up in the brain, which is decreasing the ICP, which is not good. This is a thing that's most likely to happen if you are having on your first or second dialysis treatment, where your body kind of freaks out and not everything is perfect, and now we've got an issue with extra increased ICP in the brain. And our interventions for this are going to be basically the same as if just you had increased ICP just normally. So you're going to raise the head of the bed. Maybe you're going to help, but you don't want more blood to just want to flow to the head because gravity wants to push it there. This person may also receive an osmotic diuretic, such as mannitol, okay? But with mannitol, you also want to make sure that they don't have a low blood pressure or anything. You want to make sure that they're okay as far as that's concerned, because that does cause fluid to shift from, get rid of all that fluid. Hypertonic solutions might be given. Okay? Hypertonic solutions help to get the blood, okay? Help to get the fluid out of the tissues and into the intravascular space. Hypotonic solutions do the opposite. This person will not be receiving hypotonic solutions. But they might, if it's really bad, the doctor might give them a hypertonic solution to help to draw that fluid out of the brain tissues and into the intravascular space. Now, this is kind of a risky thing. You don't want to take all the fluid out of those because then the cells shrivel up and die, okay? But in the case that this is a big emergency and you need something to be done quickly, that might be provided. And albumin is a hypertonic solution because that is literally what albumin does. It keeps fluid in the intravascular space. So this person may receive small amounts of albumin to help to draw that fluid back into the vascular system. Fatigue and muscle cramps, electrolyte imbalances. You can get fatigue and muscle cramps from I would say probably potassium for sure, magnesium, calcium, any sort of issues with those electrolytes. You can see fatigue and muscle cramps. Bleeding, that would be most likely from the site of the access, so you might want to be watching that. Of course, for bleeding, if you've got any issues with that, you want to put pressure on the bleeding to help to stop it. Infection in MRSA, take care of that site. Don't, use aseptic technique, wash your freaking hands, clean it off first. Hepatitis, HIV. Okay, these are tricky. These ones come from a dialysis machine that has not been cleaned properly. So if somebody with any of those things, those blood-borne diseases, got a dialysis before you and it wasn't cleaned properly, that is something that can happen. So how do we prevent this? By keeping the dialysis machines clean. And then air embolus. Air emboli are actually really bad. I can't spell. A rare but serious complication that can occur during hemodialysis. Air enters the venous system, which can lead to life-altering consequences. Yeah. Air can enter the system during catheter insertion. If the blood line is not connected to air, blood pump can pressurize air into the venous system. Air can leak into the circulation through the dialysis tubing. Not good. Dang. Can cause breathing difficulty, just chest pain, because it is essentially like an embolus. Confusion, bluish skin, difficulty speaking, fatigue, anxiety, convulsions, and loss of consciousness. Not good. So, I love how I'm like, yeah, it's basically an embolism. It's in the name. And it causes all the same problems an embolism would cause, where everywhere around that air embolus, as it travels, cannot get blood. It's literally a blockage. And if that gets to the lungs, it gets to the heart, gets to the brain, you're having a huge issue. Stroke, PE, MI, not fun. It's been like 2 hours. It's been literally 2 hours, I think. And this whole time, I've just been talking and talking and talking. So what I'm going to do now is we're going to pull up our dialysis presentation and see if there's anything I missed. Oh, one thing about dialysis is you have to take weights before and take weights after, because you want to see, first of all, if the dialysis was effective in pulling off all that extra fluid, and then, of course, how much weight was taken off. This person is also going to be receiving, they're going to receive heparin, like so that doesn't get clogged up in the machine, because there's blood traveling through this machine, and we don't want the blood to we don't want it to clot and block up the machine and cause issues with backflow and everything. So this person will be receiving heparin, okay, which of course heparin is an anticoagulant, so if that's circulating around somebody's bloodstream, they're at risk for bleeding. One thing we need to recognize as well is what is our heparin antidote, as it were, okay? It's protamine. Oh my goodness. So if in the case that somebody, I don't know, starts having like a hemorrhagic stroke or something, or like, is it massive risk for bleeding? Their PT time is like super duper low or something. Then we need to make sure that we have this available so that they don't have like an issue with bleeding systemically because the blood's too thin. La la la. Is there anything else that we missed? Not really. I think we finally did it. Finally, we freaking did it. We can knock this off of our list. Ah, yeehaw. What a good time.